is one particular recipe, and DNA is the spelling in that recipe. So our DNA makes RNA, and that makes a protein. Protein is the dish like recipe what you want to make. So here we have pol R1 DNA, which makes ribosomal RNA, and the protein is RNA polymerase 1. Then same with RNA polymerase 2 and RNA polymerase 3. So 3A, B, and then it is getting better. Every time I see there's a pol 1 K, new mutation has come up. This is a hypomorphic gene. The less you have, the less protein you have. You can't not have RNA polymerase. If you don't have any RNA polymerase, they present very early age and they don't survive. So everyone has RNA polymerase, but the way it works, these three enzymes are linked to each other. These three enzymes are linked to each other, so there are some units which are common in RNA polymerase type 1 and type 2, some is common with type 3, so that's why it works, but we don't know why something causes cerebellar atrophy, why some mutations are associated with corpus callosal agenesis, why teeth problem, why skeletal problem, why face problem. So we are getting to know about these conditions. I'm not a geneticist. I wish James was here. He could have explained it a bit more better. So what we know so far is called R3A. They're present early. They're more severe, and it is exactly proportional to the number of how much RNA polymerase you have. So pol R3B sometimes milder, and 1C and 3K rare, but it is broadening spectrum. So the list of clinic, all of them are autosomal recessive except pol R3B de novo, one case report there, but all autosomal recessive. I don't need to explain it to you what autosomal recessive is, and you see some with central hypomyelination, some with peripheral nerve demyelination, and variable clinical phenotype. So this was the recent case report with pol R3B, expanding phenotype on occurrence with type 1 diabetes. So I said not everyone needs to have all 4 H. We are understanding imaging is good, but we need 2 points of imaging, at least in kids who are less than 2 years old, to call it hypomyelination, and how often do we need to do MRI scan, do we need to monitor, all those things are questions which I ask myself. So severe onset, newborn baby, they don't survive. Typical onset, toddler or childhood onset, and there have been report of adult onset, which is milder phenotype. They present more with spasticity in the leg and with some changes on the brain scan. So these are all the other phenotype which has been reported: Treacher-Collins-like syndrome, neonatal progeria. They look very old when there's a newborn babies. So they have very less amount of one of these RNA polymerase. So as I told you, for S3H, this was interesting. They can get severe chickenpox infection. I didn't know that till 4 or 5 years ago. Like recurrent shingles, some parents complain about. So if I see someone, I will get their chickenpox antibodies checked, and if not, I will get the chickenpox vaccination done. Don't know why it happens, but that is something which alerts. And then the cognitive phenotype, we need to understand it better. So currently, as you know, no cure, like there's no treatment to change the spelling mistake in your gene, but mostly it is supportive, and you need multidisciplinary care. What I see, the same thing with other white matter disease, patchy involvement of occupational therapist and physiotherapist, and endocrine monitoring is also patchy. When they need hormone therapy, because hormones will affect your bone growth. It will affect the mineralization of bone. So hypomyelination is not a problem, but preventing them from things which are preventable, that should be our aim. Whenever gene therapy comes, we talk about it, but most important thing is what can we prevent them from risk of having recurrent bad chicken pox, like one of you had the experience of bad chicken pox. So, is there a role of this? These are the questions I need to ask people who have worked more, like meeting Nicole next week. So I will ask. And regular dental intervention and myopia, visual this thing that is common as well. And one of our girls had a very special smart glasses, and I asked her, will she exchange it with me? She said, no, it's very cute. It's a marquee glasses. I'm not going to exchange it with you. So keeping a good eye on myopia side of things, because if you become deeply myopic, you can develop retinal detachment. So regular eye follow-up, regular dental follow-up, someone is keeping an eye on the hormone profile, give the hormones when they need it, when they reach the puberty stage, if they're delayed, they need to get tested, all the puberty hormones and everything, because that might have implication on their general health and well-being. Okay, so I know that in sort of Phil Chop, I was there with the team. They have this marine depository biobanking program. I got the protocol from them. It's getting a bit difficult for me to get it there. They were happy to help me set up things here. So let's see. And then Nicole is doing all those work, international genotype phenotype study. So they have developed a mouse model on polar3A, and these are all in discussion. I don't think Yaya Foundation, I met with the team there. Our TLC, we are supportive. We are seeing what we can do. I think 2028, realistically speaking, if there's something has to come, it might come. So it's rare. We don't know. We don't have the natural history data. So we have taken a step to get as much information as possible from our registry, and same problem with any other rare diseases, validated biomarkers and trial endpoints. So preclinical models have been established now, and these are all how you deliver the gene therapy and everything. That always remains a challenge. And for us as a NHS clinician, I wish we had a dedicated leukodystrophy center, and we could do all those things. We could happily do it, but the way system is at the moment, we can't. It drains you. There's so much of. So in summary, think about what is preventable, how best we can support them, mobility, how best they can, how steady they can be. Do we need to work on their core muscles? We don't want them to fall. We want their bone strength to be good. Visual function should be good. They shouldn't be developing deep myopia and so I will stop there. You all have my contact detail for our data manager, and I will seek proper consent from the people who are looking after you. But first thing will be to write about our cohort. We have got 7 or 8. That is my next 6 months job. Okay, so I will send you details of what data we need, what we have. We have discussed. Before this meeting, we had another talk, so they know all of it. So, yeah.
Can I ask you 2 questions, please? Right?
Yes.
Just bring your
sorry.
microphone real quick, so.
Oh, sorry. Sorry, can I just ask you 2 questions? So, Josh hasn't had an MRI scan for about 3 years now. How often should we be asking for MRI scans?
So, normally in clinical world, we decide clinically. Anyone who needs MRI scan from our cohort, they will need general anesthesia. Now the question we ask, is it justified to do it?
What it was is, obviously, we went to see Dr. Wolf in Amsterdam, and he said it lasts for 30 days on a stick, and I'm not technology minded, so when we got to Amsterdam, she couldn't access it, so we've never been able to show her our MRI scan for Josh, so we can't. It's sort of irrelevant to us keep going over there to see her when we've got nothing to evidence-wise to give her, let's say. So could we request an MRI scan again off our hospital? And what would we do if they knocked us back? Because they're very reluctant to do it, let's say. So because he has to go under anaesthetic.
I didn't get it.
There's two bits to that. Firstly, we can send these scans for you, so you don't need to do that, and that's not a stick that lasts half an hour, that lasts 30 days.
Mhm.
We can, that's not a problem, we swap scans internationally all the time. And I wouldn't rescan my patients either.
No,
We've
so-
had that discussion.
So every time they have a PET scan in Amsterdam, it costs them $1,000.
And they're set up differently. So one in the I've worked with Rahul in Amsterdam. They have 2 scanners in hospital, one of which is purely paid for on a research basis, and one of their scanners is a research scanner. And they lend it out to the hospital, but actually it means that if they want to scan their patients, they can always do it.
Yeah.
It's very expensive, and they do a different sequence, so they don't anaesthetise all of their patients. They do a fast T2. So we don't all do that in the UK. So and different peripheral hospitals, they probably won't be able to do that scan. So they do lots of scans. They are a very research-driven centre, so it's not wrong that they do lots of scans if they do them without an anaesthetic. But actually, in the UK, we would need an anaesthetic, and if these are for interest, they're for academia, they're for learning. If we're going to put your child at the risk of an anaesthetic, I think we've discussed it before. Then actually, unless there's a clinical change,
Yeah,
I wouldn't rescan that.
No, I get that. Also,